Hi, my name is Chelsea Bristow, and today we're going to be talking about medications that are inhibitors of the renin-angiotensin-aldosterone system that are used to treat heart failure. And those are our ACE inhibitors and our ARBs. So heart failure results from chronic activation of the sympathetic nervous system and that renin-angiotensin-aldosterone system that eventually leads to progressive changes in our cardiac tissue. It can lead to myocyte reduction, hypertrophy, and fibrosis of that heart tissue. What happens with that is our heart doesn't pump as effectively, our cardiac output decreases, and our heart's not able to pump blood to the rest of the body like it should. Some causes of this are MIs, chronic hypertension, volume overload, valvular regurgitation, stenosis, ventricular hypertrophy, and pericardial disease. So ACE inhibitors, which are angiotensin converting enzyme inhibitors, are one of our first-line treatments for heart failure. They decrease the angiotensin II and aldosterone in our system by preventing angiotensin I to turning into angiotensin II. With that, vasoconstriction is decreased, so our vessels are more relaxed, our heart doesn't have to work as hard to get that blood pumped throughout our body. It is a very effective drug. Like I said, ACE inhibitors are a first-line treatment. As a CMS indicator for heart failure within our facility, we have to have these patients go home on an ACE inhibitor or we miss a CMS major indicator with that. There are some side effects. Dry cough is the biggest one, and that affects about 10% of people. Other potentially dangerous side effects include low blood pressure, high potassium, and then there is the potentially lethal angioedema that can occur with ACE inhibitors. The side effects are much worse when this is a drug-to-drug with a diuretic, and unfortunately a lot of our patients that have heart failure are on diuretics, so these can be problems. These are cheap medications. They're less than $10 according to GoodRx.com, so they're very attainable for our patients. And ultimately, the expected outcomes of these medications are just that it's not as hard for our heart to work to pump the blood around. So we're going to have decreased vascular resistance or afterload, decreased venous tone, which affects our preload, and improved cardiac output. Ultimately, it's going to improve our quality of life for these patients, improve our signs and symptoms, and increase the survivability that heart failure has. So our ARBs are angiotensin receptor blockers, and these are very similar to ACE inhibitors, except these work by actually blocking the receptors that angiotensin II binds to in order to work. It's competitive for that receptor, so angiotensin II can't connect with that. This decreases that vasoconstriction. Same expected outcomes as your ACE inhibitors. We're going to have vasodilation, arterial dilation, and our cardiac output will improve with that. These should not be combined in addition to ACE inhibitors with our drug-to-drug interaction because they work so similarly. They're going to do similar things with that. Similar side effects to ACE inhibitors as well. However, with the ARBs, they don't affect that bradykinin that can affect that dry cough and our angioedema. So these are not as big of side effects as they are with our ACE inhibitors. That's what makes ARBs, they're such a great substitute. They're an equal substitute for ACE inhibitors, and they're great for those patients that can't tolerate the side effects of your ACE inhibitors. The safety is, again, they don't have the chance of that lethal angioedema. These are a little bit more expensive than ACE inhibitors. When I found on GoodRx.com, you can find them from anywhere from $16, which is valsartan, to all the way to $71. So that may be an issue for some of our patients that we'll have to be aware of before we prescribe this medication. Ultimately, ARBs lead to a decrease in retention of our sodium and water and decreased blood pressure, which is what we want for these patients. There's no genetic teachings or links with our ACE inhibitors or our ARBs. There's also not really any environmental concerns, except for the fact that it may lower their blood pressure. So we're going to need to educate our patients on fall risk because we know if their blood pressures are dropping, they're going to be at a high risk for falls. So you may give them education just on general fall precautions. As far as lifestyle goes, these medications are pretty much safe for everybody, but they are contraindicated in pregnancy. So that's just a really quick overview of ACE inhibitors and ARBs, and just comment below if you have any questions. Thanks.